Segment 1, we're going to do symptoms and consequences. We can spend a little bit of time on it, followed by segment 2, which will be diagnosis and assessment. Followed by segment 3, which we are going to spend we're going to spend a little bit more time on this, which is ADHD management, which includes medication, coaching, and therapy. So these are the 3 segments that we are going to touch base today in today's webinar. And so before that, I'd like to start with, before I start our webinar, I'd like to introduce our esteemed panelists. So may I have the slide on our panelists so that we can share their bio with our members, with the audience? Thank you so much. Yes. Okay. Great pleasure. Today we have Dr. Tammi Quek. She's a PED with a special interest in developmental and behavioral pediatrics. She is the director of her own clinic. And followed by, we have Dr. Abraham. He is a consultant psychiatrist with Better Life Psychological Medicine. Dr. Abraham has a wealth of experience managing a wide range of psychiatric conditions, which includes ADHD for teens and children. So we also have Dr. Louise McCauley-White. She's a consultant educational psychologist. Yeah, she offers psychological consultation, advice, assessment, and interventions to schools, parents, and earlier settings. Finally, we also have Dr. Rogers. She is the founder of a Champion Coaching and Consulting. Yeah, she is an executive executive functioning coach. She and her team teaches students important executive function skills, study skills, and test-taking skills to help our children to be successful in their learning journey. Yeah, and finally, myself, Laura. Yeah. Okay, so can we start off by asking our panelists today? We have so much information of what you do, but could you tell us, in terms of describe your expertise and your roles, maybe, and how does your day look like, and what sort of role do you play in helping an ADHD child or teen? Can we have maybe Dr. Abraham to share first?
Okay, hi, good afternoon, everybody, and thank you for joining us for this talk. So a bit more about myself. So I'm a psychiatrist. I deal with children, adolescents, and adults with ADHD and also other conditions. So what is my role in this whole thing would be that I see a lot of people, especially kids who struggle in school. That's probably the main place where this comes up. Inattention, hyperactivity, impulsivity, and where it's causing an impact in their academics or with their social life or their interactions with their peers, their families. Usually they'll be having some problem of this kind. They'll come to me and I'll do an assessment. And usually at the end of it, I'll have a discussion with the child and the parents about what treatment options are there to help them move forward.
Okay. So what kind of assessment do you do? Is it written or?
Yeah, so for me, I'll be doing a clinical history. So usually my sessions for the first visit will be an hour. And one of the main tools I will use will be the DSM-5, which is the Diagnostic Manual for Psychiatrists, which goes through a comprehensive list of symptoms for ADHD to see if they fulfill the criteria or not. And along with that, then I'll also do an assessment of everything else in terms of like how are they functioning, be it in their home or in their school or among their social peers. So that would be what I would do.
Great, thank you, Dr. Abraham. Now may we have Dr. Quek to speak about what sort of role she plays in helping an ADHD child or teenager.
Hi, good afternoon. Thanks to Moon and the team for this opportunity. So I am a pediatrician. I deal with young children all the way to adults. So in terms of children where there are concerns with parents such as with attention or impulsivity or school functioning, That is how these kids usually present. But I also get parents, because I'm a pediatrician, I get kids from as young as 2-3 years old, where they are not performing as well as they should, even in preschool or in childcare. Fights, usually KY, K2, and they present earlier, but then all the way up to, I have teenagers who are going off to college, right? So many times the parents come with the problems that school has brought up or problems functioning at home or with their peers. And then we go through the whole process of the evaluation to figure out what's going on. Once we get to some sort of framework about what the child is struggling with, then I'll discuss with the parents what the management methods could be. For young children, it tends to be more behavioral approaches and parenting support. Sometimes working with the school as well to make sure that the parenting, the behavioral support is consistent between home and school, right? So rarely do we medicate kids, or rarely do I medicate kids below the age of 6, but I have done so because without the medicine, sometimes the kids cannot function, regardless of how supportive the parents and schools are.
Okay. So may I also ask that you will also perform the DSM test as well, for like Dr. Abraham?
Right, yes. And I evaluate the kids, we tend not to, or I tend to do it very broadly because many of the children who have attention issues also have other coexisting possibly learning or behavioral issues. So the evaluation is very broad-based. I will hopefully observe the child in school. Now with all the COVID restrictions, that has been a bit more difficult. Then I'll bring the child in and actually work 2-3 hours with the child, sometimes over one session, sometimes over two, looking across all the learning skills or developmental skills, because some of them have developmental delays or language delays or fine motor delays on top of their attention issues, right? So in order to really comprehensively address the attention issues, we also have to address all the other areas of skill that they are weaker in. And many of the ones, especially for the preschoolers, a lot of it is aimed towards as seamless a transition as we can to get them into primary school, because it's always the time point of concern, right? So yeah, so it really depends on what the child's struggling with, and then the management will be then tailored accordingly.
Thank you so much, Dr. Quek. Now may we have Dr. McCauley to give us how she works with ADHD kids.
Okay, hi. So I'm an educational psychologist, and educational psychologists are concerned with looking at factors that may impact a child's access to education. So I work with children throughout, and teenagers and actually young adults throughout the lifespan, because we're thinking about things that impact their ability to demonstrate their full potential. So in terms of my role, I don't tend to work with very young children. Those younger children, if they get referred to me, often I'll refer through to a pediatrician like Dr. Tammi Quek. So because I prefer not to work with very young children, because as Dr. Quek said, often there's a lot of developmental issues which need to be addressed at that stage as well. So typically I'll only work with children from about 7 years onwards. My assessments are very standardized. Educational psychologists are very much, we like to do things in a specific way. So I use standardized assessment, probably quite different to perhaps what Dr. Abraham does. I always do a cognitive assessment, because it's not about trying to find out what a child's IQ is, but what we want to see is things that might impair their ability to demonstrate their true potential within a classroom environment. So, for example, a child may be exceptionally bright in terms of their thinking and reasoning skills, but they have weak working memory or processing speed. And what we say is, okay, well, what does this look like for a child within a classroom situation? How can the teachers assist a child, but also what accommodations are going to be very useful for this child so that they can show their true potential? Then I also often do an academic assessment where we're looking at things like foundational skills, foundational literacy, mathematics, things like speed of reading. A lot of ADHD children can be amazing readers, but their reading comprehension is sometimes impaired because of the fact that their mind is flitting elsewhere when they're reading, and therefore they get to the bottom of a passage and they kind of go, oh, I'm not too sure what that was all about, and they have to start again. So looking at the things again that will impair their ability to keep up with the pace of learning in a classroom environment. I will do a standardized assessment, which is usually the Connors, which is a very good diagnostic assessment. It's the kind of gold standard assessment, which helps us to understand whether a child has a diagnosis of ADHD based on the DSM-5 that Dr. Abram already mentioned, and does the child meet the criteria based on the symptom count. This also helps with what we call differential diagnosis. A lot of young people who have extremely high levels of anxiety can present like ADHD students. However, they don't have ADHD, they have anxiety. Therefore, we need to address the anxiety, which we look at in a very, very different way to how we would support a young person with ADHD, for example. I also do an assessment of executive functioning because, as we all know, the executive functions are generally weak in about, I would say, 90% plus of young people with ADHD. And in teenagers and young adults, the executive function weakness is actually their biggest impairing factor. Because if you can't plan, if you don't organize, if you can't manage your time, you can't get things done, you don't hand in your work, therefore you don't get the grades. Okay, and then based on my assessment, we look at intervention strategies, what's going to be appropriate for the individual. So it's not a blanket assessment of, okay, I give you all the same recommendations. It's very individualized. And then I refer out to psychiatrists, clinical psychologists to support the emotional needs, and also professionals like Dr. Vicki Rogers to support children with their executive functioning, study skills, and those things that really impair their ability to demonstrate the potential in a learning environment.
Oh, thank you so much. Very informative. Now, can we have Dr. Rogers to talk about executive functioning? Wow, so interesting.
It is interesting. So like Louise, I'm an ed psych. I'm also an educator. My team and I work with a lot of really smart, but often very scattered students. If they come with neurodiverse challenges and neurodiverse learning profiles, which is predominantly what we're talking about here with unlocking ADHD, then we work with them on executive functioning skills to try to kind of do what you guys are doing. Actually, unlocking ADHD is really unlocking their potential to access the learning to executive functioning skills, which gives them access to learning in school and achieving some of those big goals that they have in life. So we do work with students predominantly. We're a team of educators who have all worked in schools and been in the trenches with students, and that is at the core of what we do. Executive functioning, and maybe just to kind of back up and what is it, because Louise did a really good job talking about how important it is to just sort of unlock and access the rest of a student's learning potential. And it isn't just a student thing. Adults who are working through ADHD and who are having challenges with ADHD, they also benefit from this. And then frankly, I mean, really anybody who can, who are having challenges with productivity, task initiation, cognitive flexibility, frustration tolerance, executive functioning skills can help with that too. So, you know, okay, I mean, the diagram probably does the best illustration in talking about what exactly executive functioning skills are, but really it's a collection of interrelated cognitive and self-regulatory processing that's responsible for problem solving and helping individuals achieve their goals. So broken into 3 buckets, you've got frustration tolerance, cognitive flexibility, working memory, also known as short-term memory. And Dr. Louise talked a little bit about what that is and how important that is, and then processing speed. So there's a lot bundled into this sort of schematic, and our job is to unpack those, to understand where the individual is in each of those domains, if they need to have a little bit more focus in one of the domains, or if indeed we're working in all 3 of those dimensions. We work really closely with strategic partners, and you're seeing a lot of them here on the panel today. When someone sees Dr. Quek, for example, and there's a pharmaceutical prescription, the executive functioning pairing to that is pairing them up with a med diary so that they can start to track and understand how they're responding to pharmaceuticals and calibrate that quick. If we're working with them in a learning dimension, we're teaching them study skills and test taking skills. We're teaching them organization skills and time management skills. And really it is a very personalized process because they all come to us with their own very personalized profile. But I think at the core of it is really understanding, and Dr. McCauley mentioned this, how critical executive functioning skills are in determining and predicting an individual's future personal, academic, and career success. So the sooner we start this sort of understanding of what COVID had a little bit of a silver lining in the executive functioning world, because it allowed parents to kind of see how their students were learning when they don't really have access to them for 7 hours during the day when they're at school. And it also insisted that students step into an executive functioning profile and faculty to be able to do online learning and learn in capacities that they didn't previously have to execute on. So in the executive functioning world, COVID had a big silver lining in that it brought this very important dimension into a very important public space, so that we're talking about it as educators. Schools are much more deliberate about making sure that that's in their faculty meeting notes and talking about how they can integrate it into their classrooms and into their lessons. Parents are talking about it. So this isn't a mystery anymore. I think still understanding the so what behind the what is the journey that we have, but that's a lot of what we do in here.
Thank you. It's wonderful. But if I have a child and I want to get a diagnosis, so we're talking about symptoms and all that, what sort of symptoms should I be looking for? You know, especially under 6. A lot of times they tell you, oh, your kid will outgrow. Your parents will tell you, oh, you know, they will get there. But what sort of symptoms or critical early signs that we can look at for young children all the way for maybe under 6 and or above 6? Maybe Dr. Quek could share that with us. Oh, Dr. Quek, sorry, could you unmute yourself, please? Thank you.
Okay, sorry. So if we're talking about preschoolers under 6 years old, right? Often I find that parents are extremely tolerant of their children at home. And especially with screen time being the common nanny. And the kids are quiet during screen time, right? But they get a lot of screen time. And then with all the COVID stuff going on, you know, they get a ton more screen time. So the kids are generally quiet at home, or at least not difficult to manage. But the school teachers are the ones that will usually flag up that there's some issues for a variety of reasons. One is that when you function as part of a group, regardless of how young you are expected to have some degree of regulation, right? You are expected to be able to follow teachers' instructions, to stay with the group, to not run around when teachers ask you to sit down, right? And also to slowly get more and more independent in your self-help skills. So if a child is, you know, after a year, 2 years, they are in N1, maybe N2, and they're still running around when they're supposed to have carpet time, or running around when they're supposed to have meal times, and teachers are after the child, then, you know, some preschools are, again, very accommodative and very positive with the child. They may feedback to the parents that the child is active, but otherwise they're fine, you know, and we give them time, and that's completely understandable. The panic comes usually, at least for local kids, K1, K2, because that's when the academic work starts coming in, the like more proper, formal, sit-down tabletop work. And many of these kids cannot stand pencil work. They will resist writing a lot, right? And often to me, like handwriting is the ultimate torture for these kids. But you know, it then impacts on the general learning, on their social functioning, because you know that's when the kids start to actually sit down and talk to each other. They're not running around playing catch anymore, right? The girls tend to sit down and gossip faster. The boys are still playing catch. So the boys tend to have a bigger runway before people figure out that there's something not quite right. And also saying that, I think we'll touch on this later on, how the girls present with ADHD is slightly different from how the boys present with ADHD. So anyway, back to the preschoolers. So the impact on academics is usually what would drive local parents for help. If there are fights in school, so I've had a few kids whereby they were always the naughty ones. If anything happened in class, they were the ones that will be blamed. Whether they were supposed to be blamed or not, it didn't really matter. Now, after 3 years in the same preschool, they were always the one to be blamed if there was any fight in the classroom. Okay, so So the social functioning, many of these kids are very friendly, they want friends, but because they're so impulsive and they're blurting and they're sometimes physical, they're hitting not with many malicious intent, they're hitting as a reaction to something. Many of them can't find friends or they can't sustain the friendship, right? Then again, by 4 or 5, because they're then even more, they're more active at home in the sense that they never quieten down. Parents then find it a little more challenging just because they don't quieten down. It's harder for them to learn the spelling. It's harder for them to do whatever homework the school has given, right? And I've had some families where the child could not be accepted into enrichment class because the child couldn't function as part of the group, right? So again, many parents would then hold on at least until K2. So the panic usually starts at K2 because of primary 1. That's usually the trajectory. There are parents whereby they're very open and they want to come in early. The moment they figure out something is not quite right, especially the mothers, I tend to trust mother's gut. They tend to feel something is not quite right. They're not quite sure what is not right. It's just not right, right? And they are the ones who usually take the first step with or without, agreement with their husbands, and that's absolutely fine. Right, so that is usually what will happen for the under 6s. Yeah.
Wow, okay, so it's usually about not following teachers' instructions, not able to get so independent themselves, and also a problem with social skills, fights or arguments, and and always the teacher says that if he's in trouble, it's always that kid. So these are some of the early critical signs.
Yeah.
Okay, so can I ask Dr. Abraham, okay, so what will happen if the ADHD child continues to be undiagnosed or unmanaged? What are some consequences that you can share with us?
Yeah, well, sometimes it depends on the overall functioning of the child. So a lot of kids, it may be picked up, like as Dr. Quek mentioned, if they start, being disruptive, they get labeled as the naughtier kids in class, especially those with the hyperactive component. Now, ADHD, you must remember that not everybody has all components. You can have those which are just purely inattentive, and these tend to slip under the radar because they are the ones who are sitting quietly, daydreaming in the corner, or they look like they're paying attention, but actually they're not. Right, but because they're not disruptive, they tend to be picked up less often by the teachers. The ones who are very hyperactive and impulsive are the ones who often are picked up by the teachers earlier as having problems. And because they're problematic in that sense, they may end up getting an assessment, and then people find, oh, by the way, they have ADHD. But those inattentive ones tend to be missed, and they tend to slowly struggle a bit later. Or I find that those children who are actually quite smart and intelligent, they find other ways of compensating. And sometimes they may be completely missed throughout the entire primary school because their results are sort of okay and they're sort of performing okay, but maybe not quite to their full potential, but everybody assumes that maybe that's the maximum that they can do. And it's only later when at some point their intelligence is not enough to compensate for the level of work that's being given to them, and that's when the results just start to deteriorate quite badly. Another aspect of where they get affected if it's not picked up early is that those kids who are either labeled as naughty or those who are struggling academically and the parents or teachers label them as not working hard enough, they may start to develop depression and anxiety. So kids with ADHD actually are more prone to also getting other mental health issues, like adjustment disorders, depression, and anxiety, social anxiety disorder, and then other conditions start playing a part. And then you may have more than one condition that needs to be addressed.
So my understanding, so is usually if it's undiagnosed or unmanagement, probably the key areas that the consequences are probably academics. They might be able to manage in the early years, but as maybe they go to secondary school, there are more subjects, more expectations, they tend to derail. And also maybe probably self-esteem, they get labeled. And probably these are the two more common key consequences. Can I say that?
Yeah.
Dr. Abraham, from what you just said. Well, thank you so much. So we have completed the first segment, which is the symptoms and consequences. We will come to the next segment, which is diagnosis and assessment. So, Dr. Abraham, you were just talking, you mentioned that how you make a diagnosis is through your DSM paper, right? Or I mean your test. But I just asked your questions. If your child is under 6 or even under 12, to do that test, is it very long? How long is that test?
Oh, well, it's actually more of a clinical interview rather than a test. Which goes through a series of 10 symptoms of inattention and 10 symptoms of either hyperactivity and impulsivity, and then combined with the rest of the comprehensive interview about the background. So it's not a test per se. So your question was, how long will it take, is it?
Yes, correct.
So my assessments are usually an hour for the first
an
visit.
hour. Okay. How about Dr. McCauley? How long are your tests? And if the tests are too long, the children get very frustrated. Even say a normal kid.
Absolutely. So I tend to break my assessment up now into components, especially now that I've been assessing through COVID remotely. So I find that actually breaking it up into smaller sections and doing it over a few days is actually better. But also one of the things that you need to remember is when we are making a diagnosis of something like ADHD, and say, for example, we're looking at inattention, one of the kind of key diagnostic criteria is that something is not developmentally appropriate for that child's age. So chronologically, it doesn't fit, okay? Because that's one of the key diagnostic criteria. So if I'm now do an assessment with a child and I would expect them based on their age to be able to sit and focus for an hour. Now imagine how long those lessons are, and especially in the Singaporean schools. So the expectation of I need you to sit for an hour so that I can do this test with a 10 or 11-year-old, and they can't do that. That in itself is very, very telling, actually. So a diagnosis is not purely just based on ticking the boxes and saying, okay, the child meets it based on standardized assessment. There's a lot of observation. There's a lot of qualitative information that actually comes from doing these formalized assessments. What is the child doing? So I might be working with a child and the feet are up on the chair and they're virtually doing somersaults on the chair whilst they're trying to complete the task. So that in itself is really vital information to the person who's actually assessing this child, because it tells us a lot about their inattentiveness, their impulsivity, their hyperactivity. For example, children who don't listen to the task instructions before rushing off ahead and trying to complete what they think is what they need to do. That tells us a lot about impulsivity and the inability to wait for the teacher to give the instruction. So there's a lot about the assessment that, yes, I know they are long and they take a long time to do, but what we're looking at is atypicalities in terms of their ability to focus or listen to instructions, and that does tell us a lot. And I do split the assessment because what we're also trying to do by doing a lot of this formalized assessment is understanding the true ability of a child. And that in itself has so many benefits for the young person and for the parents, because, as Dr. Quek and Dr. Abraham said, a lot of times these children, they're falling through the net. And as they get older, they start developing a negative narrative about their skills. So they start using words like, I'm stupid, I can't do this. So by doing these assessments, you can understand their true potential. And one of the vital things about doing this assessment is to not push them to the stage of being so exhausted or so inattentive that you're actually not getting the best out of them, because you want to know what is this person's true ability if we were to intervene and support them to manage these ADHD symptoms. So for a parent or for a school, and often with schools, because I work with schools, and you send these very long and detailed reports, and a school will pick up the report and go, I had no idea that this child was so bright. I've never ever seen this potential whatsoever. And then that in itself helps us to say, okay, so what are we going to do to support this child so that they can demonstrate this potential that we've now seen through the testing within the school environment. So it's a complex process, assessment, And I think a lot of the time it's based on the professional expertise of the person who's working with that child to manage the assessment in the best way based on what they feel is appropriate for that child. So again, like Dr. Rogers said, everything we do is very individualized to that student. It's not a one process fits all type of assessment, because you're going to see differences in every child that you work with.
Okay, so that's not like one test that all ADHD kid goes to. So
I would recommend for any psychologist working with a student who's potentially got ADHD to do something like the Conners rating scales, because they're seen as the gold standard of diagnostic assessment when it comes to ADHD, but you're doing it from different perspectives. So I always send one to the teachers, sometimes even more than one. So different teachers' perspectives, the parents, the young person themselves as well, because again, if we're looking at the diagnostic criteria, the behaviors that are being observed need to be observed in more than one environment. So if you've got a parent saying, oh, my child's jumping all over the furniture at home and they won't pay attention and do their homework, but then the teacher says, never seen these behaviors before, this child is an absolute angel at school, everything gets done, there's no concerns academically, then we're going, okay, what's going on here for this child? This maybe is more of a behavioral issue, it's more environmental. So that is why the importance of getting the views of different people who interact with that child and are part of that child's life. As I said to you earlier on, I always do a cognitive assessment because there's certain profiles that you see when you're working with these young people. Working memory, processing speed tend to be areas within that cognitive profile, that learning profile, that are impaired in people who have got ADHD. And once you start addressing the ADHD, then what we can see is that the working memory may improve with this. For example, with medication, working memory can improve because our working memory is our ability to filter out distractions in our environment in order to mentally juggle information in our mind. If you're distracted by stimuli in your environment, you therefore can't use your working memory optimally. So there's a lot to a psychological assessment, actually. And as I said, it's not a one size fits all. And it's just being cautious about the age of the child. So, for example, one of the assessments was called the Conners Continuous Performance Test, and it's a 14-minute test of variable attention that the child does on a computer. I find the results of the CPT are great for primary school children, but they're not great for teenagers, because to expect a teenager to focus on a 14-minute computerized task is not really asking much of them. So you might see CPT results being absolutely within the normal range, but then all of the other measures that we're using do show that we've got an ADHD profile. So triangulating the data, getting as much information as possible and not making kind of quick assumptions based on only one or two tests is really, really important.
Thank you so much. For Dr. Quek, if we are to come to see you, what sort of information should we bring so that you can assess our child better?
Well, anybody who was wrong at my clinic will know that I'll end up sending very long questionnaires to parents and asking also teachers to fill out very long questionnaires to give me, and that's before I meet the parents, to give me some background on the concerns. And then, I do spend quite a bit of time getting information from parents about what's going on at home, what's going on in school. And also, trying to figure out what the home dynamics are, because although the focus a lot is on how the children are functioning in school, a child with ADHD does become a source of a lot of parenting stress and marital stress, and even siblings, get affected. So it's really not just focusing on the school end, but on all aspects of the child's functioning throughout a day, right? Because again, many of them do have sleeping issues that start from very young. Like I have kids where they've never slept. They were always hard to put to sleep. They would never sleep for more than 3 hours, right? So sleep issues are not uncommon. Eating issues are not uncommon. So it's looking at the whole thing. Once I've got information from parents and teachers, I then do my bit, which is, have eyes on the child. That's when I want to do the observation in school, because that gives me a bit more information about how the child's functioning within the classroom, which is, where they spend most of their day, right? After that, when I had the child with me during the evaluation session, that is when I would do not as much as what Dr. McCauley would do, but enough in terms of cognitive ability or developmental level, the language skills especially, and whatever skills are expected. So I don't expect a 3-year-old to write, but I do expect a 3-year-old to play with like Duplo blocks, right? And then depends on the age of the child, whether it's a preschooler or primary school or even secondary school, although those I tend to send out. But part of the evaluation process, again, is not just to get to the final result of where the developmental level is, but also to see in terms of general behavior. So the child is working with me and unfamiliar adult, they are in a strange environment. If they are socially aware, they would be on their best behavior, at least for the first half an hour, right? After the first half an hour, you start seeing the behaviors. So I've had kids where they're under the table, under the chair, running out the door, pulling stuff off my shelves. Now, again, we look at it purely from a developmental point of view. It's like, okay, this is kind of behaviors that you have. This is what your parents are dealing with. This is what your school may be dealing with, right? And that also takes, it's a big factor when I'm trying to figure out what is the best approach to help this child. One thing, though, to remember is that, as Dr. McCauley said, some part of the diagnosis of ADHD requires that the child's behavior is noted across different settings, at least 2 different settings, right? So ideally home and school. But caveat being that many of the girls, especially inattentive girls or even hyperactive girls, can mask themselves in public. In other words, they look normal. They look normal, all right? Mm-hmm. And they are often not as hyperactive or they don't manifest the hyperactivity as what the boys do. The girls' hyperactivity tends to be more, general fidgeting, twirling your hair, twirling with your necklace, munching stuff, snacking nonstop, chit-chatting, very social, very chatty, very talkative. If you think about it, I'm sure that we all have a lot of girlfriends who exactly fit that profile. That's what girls do. But they get away with their fidgeting because it looks socially acceptable, right? But then when you sit back and you observe the child over an hour, you realize the child never really stopped. There was always some movement somewhere. So you can clear, I kids where we clear the table, but they play with the eraser shavings. After they've done their work and they erase stuff and they play the eraser shavings, or they play the nails, they play the rings, they play with something. So when we're evaluating, that's what we're looking for, right? And then the other thing that, sometimes I would also do, especially for the very young ones, would be what's their social awareness? Do they know, can they read a facial expression? Can they read that I'm getting angry? Now, it's not that I get angry, hopefully, but because of the mask, a lot of the young kids, and that's why I'm concerned about a lot of the very young kids, the 2-3-year-olds, the moment they're out of the house, everybody's in a mask. So they're not actually getting the training that they need in order to read facial expression. I have no idea what I'm going to be saying 5 years from now when all these kids become primary school level. Yes. Because we've had 2 years where they are training kids to only observe eyes. They understand cause and effect socially. If they do this, this is what will happen. Because some of the kids don't. They can't figure out why they're being scolded. They don't link it to something that they originally did, right? So it's really looking through the whole spectrum, because all of these need to be addressed. I mean, I can medicate. That's not the issue. But the medication doesn't teach you the skill, right? So then we have to figure out what skills we have to teach. Again, aiming for optimal functioning in school and peaceful functioning at home. For the child, but also for the family, because it often impacts the whole family dynamics. Yeah.
So can I just ask, so as a parent, I want to get a diagnosis. Can I see Dr. Quek, either Dr. Quek, Dr. Abraham, or Dr. McCauley? So who do I go? I can go any of you? I mean, that would be my question as a parent. Yeah, technically, right. Am I correct to say, Dr. Quek?
Yes. I would say technically, definitely. I think, as I said to you right at the beginning, it's all, there are differences in our roles. So, for example, if you think about school-based support and accommodations, as an educational psychologist, a lot of the recommendations that I give in one of my reports is very much based on the educational context of the support this child needs. You know, for exams, for example, what is this child going to require in order to put them on a level footing to their peers? So, for example, things like additional time, maybe laptop use. As Dr. Quek said earlier on, holding a pen is a huge issue for these kids from a very early age, which means often we see additional diagnoses with these children in terms of things like specific learning disorder of written expression, which maybe everyone will know the word dysgraphia, for example, because that's kind of what it used to be packaged as. So what are the accommodations this child needs? And the exam boards, more so international schools, I know we're mainly thinking of MOE schools here, but what do they need in order to grant the child the accommodations that they require? And the exam boards need a qualified educational psychologist to make those recommendations, for example. So it's really different, I think, depending on the age of the child. And that's why Dr. Quek and I have always worked so very closely together, because often Dr. Quek will see much younger children. She will make the diagnosis. Then they're a little bit older. Dr. Quek will send the parents to me and say, okay, they've got a diagnosis of ADHD already, so that's not my role here. But taking into account that diagnosis, what are the other additional educational factors that we are seeing here? What can the school do to support? What are we thinking about in terms of the next few years with them sitting exams and tests? So I would say there's a partnership between us as professionals. There's no standalone person who's going to go and do everything. I refer to psychiatrists like Dr. Abraham when I'm working with teenagers, specifically teenage girls, who tend to have extremely high levels of social anxiety, who have anxiety often as a result of their ADHD. You know, the comorbidities of the anxiety and the depression. When we were watching that video earlier on, the one 21-year-old girl was talking about the anxiety and her depression. So then I'll refer a young person like that to Dr. Abraham to address those additional comorbidities. And then, as you know, what I've said already, I referred to Dr. Rogers to work with children and teenagers in terms of the executive functions. So I think as much as we're kind of a panel now in front of you, that panel exists in practice as well.
Thank you so much. That's very informative. I think that's very, very helpful. So now we'll move forward to our segment 3, which is ADHD management. So I think the biggest question here is medication, which also includes coaching as well as therapy. So to our panelists today, you know, as parents, we frequently feel a need to manage our kids, or even our teenagers. So our children actually feel powerless, and sometimes they frequently rebel or reject. So we believe that best results are achieved when both parents and children work together as a team. How would you advise parents as well as children for a possible outcome? Maybe we can start with Dr. Rogers first.
So what's really helpful, and I'll just reiterate how important it is to have an accurate assessment done, because that is really my manuscript. When I get those manuscripts and I get those assessment results in, I take that with my team. I have a team of tutors that are subjects related tutors that are also trained in executive functioning, and we really unpack that. And then we look at those 3 dimensions of executive functioning, and we figure out, well, where's the greatest need and how many of them can we, well, primarily, what are the most important ones to address first? It's so interesting with COVID, the travel stopped, everything that we knew in terms of everyday normalities kind of ceased to exist the way that we knew them, but school just kept going. And so, you know, we're always at this tug and pull space where we're trying to build some really strong, important executive functioning skills to allow kids to even just task initiate so that they can access their learning and get stuff done at school. But, you know, that's not really our end game. Our end game is to get them to enjoy the learning process. And through that, there's a lot of preliminary steps that need to be understood in terms of what their learning profiles look like, so we can prioritize where there's need. So for example, a day in the life of an executive functioning coach, me, and working closely with my tutoring team might be something that comes through on either Dr. Quek and or Dr. McCauley's report that will say this particular student has needs in the math related space. And so we'll take an executive functioning approach to understanding, okay, where are those needs? Is there a gap in math? Do we need to take a specific look at that? How do we organize a roadmap so that we're filling that gap, but that we're also not dismissing what the student currently has to do, because schools don't wait for kids to catch up, although they are working really hard, you know, within the, I worked in schools for 25 years. So, you know, we've got a bandwidth, and we're constantly exhausting that bandwidth, but even within that space, there's just so much that we can do in the classroom when we've got a cohort of 120 students. So how do we fill some of those spaces? If there is cognitive flexibility challenges and frustration tolerance challenges, and they're really struggling with that, then we partner and we think about, okay, how we can't stop the school. So we've got to continue with the study skills and test taking skills and that organization and time management component. But we do need to be also addressing some of these other pieces, because sometimes that allows them to get to this other space of learning. And so we take an approach on that, and we figure out, well, predominantly, and the research is really quite clear about this, in order to access any executive functioning learning of significance, a child, a student, a teenager, a young adult, they really have to feel the safety of a strong adult relationship and network, whether it's at work, whether it's at school, whether it's at home. So then we think about, okay, well, what's the story here? Is there a digital usage issue? Is there a sleep issue? If the child doesn't sleep, nothing works. And Dr. Quek can prescribe medication. We don't see that optimized. We can teach executive functioning skills. We don't see that optimized. And so, you know, we really do kind of unpack that piece to make sure that we're working sort of in this triage of support and making sure that we're meeting some of those preliminary early goals. What we're always up against is time. And it's not so much the time of school, but it's the time of tolerance of the individual. So by the time students get to us, they've been through a lot of school and they're frustrated. Sometimes they have counselor fatigue. And by counselor, it's everyone who's ever tried to help me in my life. Any real counselor, doctor, parent, church member, pastor, coach. And so if we get obstinance mixed up in that, and there's oppositional defiance, then we have to work through that as well. So, you know, it's a multidimensional process. In this space, we don't have time to specifically unpack each of those steps and to, you know, to give an actual tangible example of what an active study strategy looks like versus a passive study strategy. But I would say, you know, Moon, you and your daughter were a great example of how you came to us with a really strong foundation of safety and a really strong network with your community, but also a great rapport with your daughter. And that allowed us to move very quickly and make some massive progress in scaling up executive functioning, study skills, and test taking skills. And so her daughter did very, very well, ultimately, even though she was diagnosed quite late.
So, I mean, you mentioned something about medication. So I just like to ask all the panelists, is medication necessary? Is it a must, or we can wait and see? And if it is so, Dr. Quek, would you like to start first?
Right. I think of medication as one of the tools that can be used. Just because there's a diagnosis of ADHD doesn't necessarily mean you need to medicate, right? And decision to medicate is very difficult for parents, and I completely understand that. But what neurologically is happening in the brain is that by no fault of the child or the parents, there is an imbalance, there is insufficiency of certain neurotransmitters in the brain, certain chemicals in the brain that we all need to function well, okay? And what the different medications can do is almost like to increase the levels of whichever neurochemical is sort of insufficient, okay? So in other words, you think about it as, you know, leveling the playing field. The child did not ask for his brain to be inattentive or to be thinking 20 thoughts at any one time, right? This is just how his brain was wired from birth. We are asking, you know, and he will cope, or he or she will cope as best as they can because they want to please the parent. At some point, the behavioral strategies are always the first step, especially for the young ones. All the, you know, big associations and, you know, guidelines will all push behavioral work, parenting work, and we can talk about that as the first line, okay? Now, if that is helping the child cope well enough, that's fine. You do not have to medicate, all right? At least until the task demands in school, as they're growing higher and higher up into, let's say, primary school or secondary school, just the behavioral supports are insufficient for the child to perform optimally. The end point for me, as in one way to think about do we medicate or not, is how are the ADHD symptoms affecting my child's functioning? Functioning as in academic functioning, social functioning, right? Does he have friends? Can he keep his friends? Is he happy socially? And home dynamics. Is this particular child the cause of 90% of my parent's marital dispute? And sometimes it is, okay? Now, if some of these issues are directly related to the ADHD symptoms, right? So we are affecting, in other words, the ADHD component is affecting the child's quality of life, okay? Despite maximal support from school, from home, from parenting, from whoever else, then, we may have to pull out the last tool, which is to use medication, right? The thing with medication is that it works so long as you take it. So it's like your glasses. Your glasses work so long as you wear it. It doesn't actually change your eyes. The medicine doesn't actually change the brain permanently in any way or form, okay? But what it does is that for the period of time that it works, it settles the brain enough that the child can actually stay with it, can actually focus, can actually calm down, can actually learn the stuff that they're supposed to be learning, all right? And importantly, execute what they are supposed to be executing. So I have many primary school kids where through a lot of parenting, a lot of training, working with psychologists, they and in that moment of time in the playground, execute it because they can't calm down and stay calm long enough in order to do the correct thing. So they're impulsive, they will react. And they will then know 1 millisecond after they have reacted that they have done something wrong. And then they get anxious, and then they get defensive, and then they get oppositional, and then everything happens, right? Mm-hmm. So especially for kids with impulsivity, especially the young ones in like early primary school, kindergarten, the impulsivity is the one that gets into a lot of trouble. Many teachers, even local schools, many teachers are much more tolerant now of kids who have to move around the classroom. Not like when we were in school where we all had to sit. They are tolerant, but no school can be tolerant of a child who suddenly slaps another kid or suddenly pushes another child or throws something at another child, right? And that's completely understandable. So in some cases, medicine is used almost as a way to help the child, right? None of them change the brain. The moment you stop it, that's it. Right, but for I can buy the child, let's say 8-10 hours of where they have control and they can actually not worry about it, actually get on with their life, right? The other thing for parents to take note of is that starting medicine doesn't mean you have to be on medicines forever and ever, right? We can stop it at any time. It's just a matter of how fast we can stop it. All right, so in many cases, and I don't deal with the adults, but in many cases, I've had kids where the parents are on medication and the parents can tell me, right, they take the medication on days where they have back-to-back meetings, where they have to sit still, right? They do not take the medication when they are traveling from site to site because they don't need it. So as an adult, hopefully if we do our jobs well enough, the young person or the young adult is aware enough of how their brain functions, has enough strategies under their belt to manage their inattention, distractibility, time management, that they are not dependent on medication. Even off medicine, they can function, they just will not function as optimally as they would wish. Right, so the good thing about ADHD management, ADHD medicine is that it's very, very flexible. It's one of the most flexible drugs you could possibly use, right? There is resistance to any medication that affects the brain. So sometimes parents will tell me, and the way they rationalize it to themselves is that if the doctor tells them that the child has pneumonia and needs to be started on some heavy antibiotics, no parent's going to say no, right? Same thing, the child has something going on with the brain, there's medicine to help him. Are you going to say no? Right? But yeah, it is a hard decision. With regards to how young, I try to not meditate before they get close to primary 1, so 6 or 7. But I do have preschoolers where we have to medicate because they come in the classroom, can't function in K1, K2, and therefore they can't do their learning, which is in our local situation is where all the early literacy comes in. Right, by K2, all our kids are more or less supposed to be able to read because by primary 1, the sentences are coming in. Right, so when I have a child who's very hyperactive, very impulsive, very inattentive, and they can't even get through the phonics at K1, know their letters by 2, it is going to cause a problem. Yeah.
Thank you. Dr. Abraham, do you have anything to add in terms of medications? Would you like to share with us what are the possible side effects of long-term medication? And yeah, Dr. Abraham?
Yeah, Dr. Quek, I think, explained it very well.
Yes, yes, she did.
So I guess the only thing I would add is that what Dr. Quek was talking about mostly were the stimulants, which are the commonest treatments for ADHD. But there are some people who don't tolerate those stimulants, and there are some other medications which are taken on a more daily basis, like guanfacine, but that gets a bit more technical. But let's focus on the stimulants. So these are the ones which, so you were asking about side effects. The 2 commonest side effects would be insomnia and loss of appetite, right? So these are things which would have to be managed, but in terms of the insomnia, it's usually not a big issue because the majority of the time the medications are taken in the morning. And depending on which version of the medication you take, immediate release lasts for about 4 hours. The intermediate release is about 8 to 12 hours. So if you take it 6 o'clock, 7 o'clock in the morning, it's not really going to last until bedtime. So the sleep is not usually affected. Quite commonly, a lot of parents are worried about it because for those kids who have a lot of thoughts going on in their head, you know, already they're having trouble falling asleep because these thoughts are going on in their mind and they're already having insomnia to some degree, right? But usually it's not a problem if it's taken early in the morning. A loss of appetite is, it can be fairly common as well, but that's why we usually advise our kids to take the medication after breakfast. And then maybe at the break time, at lunch, maybe the appetite won't be so great. But usually the medications will wear off again by the time you come home. And dinner is not a problem, or they might have a late lunch. But not everybody has the loss of appetite. There are some kids who are totally not affected at all. And other side effects that could happen include headaches, palpitations, maybe an increased anxiety, maybe mood swings, but these are much less common. And the majority of the patients that I see don't have any side effects at all. And the common ones are probably just the appetite loss.
So I heard some parents, they medicate their children on a weekday and on the weekend or school holidays, they give them a break. Or is that something that is fine, or should they be medicated throughout so that there's some sort of momentum going on? Dr. Abraham.
Normally, I actually advise my patients and the parents to not medicate on the weekends, school holidays, and public holidays, because giving themselves what we call drug holidays actually helps the body to remain sensitive to the medication. I've got a handful of clients who ignore that advice and continue to take every day, Saturday, Sunday, all the way through. And after a while, they come back and say, hey, actually, I don't feel it's working as effectively as before. And then we need to kind of give them a bit of a break for a while. And then the medication usually is, they're sensitive to the effects again. So again, I'm talking about the stimulants, but there is another medication called guanfacine, which I use quite a bit of these days. It's more closely related to a blood pressure medication, actually. And these are actually taken on a more daily basis because they're not so immediate as and when as stimulants. And the side effect profiles are a little bit different. So it's more likely to have like sedation, low blood pressure, giddiness. But again, if we start on a very low dose and gradually go up, a lot of patients are actually able to tolerate this medication with minimal side effects. There's a third type of ADHD medication called atomoxetine, which is also used for those who don't tolerate the stimulants and who don't tolerate guanfacine. I've only used it a handful of times back when I was in IMH because personally I didn't have a lot of good experience with it. But that would be a third option for those who don't do well with the other two types of medication.
Okay, Dr. Abraham, thank you. So we haven't talked about medication. Now we move forward to talk about coaching. So we'd like to ask Dr. Rogers, executive coaching, how interesting. Would you be able to give us some tips? How do you work with the ADHD child in terms of coaching? What are, or some simple tips that you can share today with parents, you know, what we can do for our ADHD kids?
Sure. I mean, I'll just piggyback on the medication piece because that bleeds into the learning space a lot. So I'll just give you an executive functioning tip about that. Sometimes, often, teenagers don't want to be any different than anyone else. And if they perceive, whether it's the reality or the truth, that they're taking medication and their peers are not taking medication, we get resistance. So what I try to do is we get an understanding of if the decision is by the family, yes, we're going to go down the pharmaceutical route. We try to calibrate that as quickly as possible. Mm-hmm. At the core of executive functioning awareness is metacognitive awareness, right? So then we put together some tools, the med diary, I alluded to that earlier, and I teach them about, okay, here's a med diary. What we really want to do is we want to take a morning, noon, and night pulse of how you feel you were doing during the day on medication. Now, the older the child is, the better they're going to be able to do this. Sometimes I'll have a parent or I will text them at a certain time and I'll have them give me a number from 1 to 5. So then when they go back to Dr. Quek or Dr. Abraham, they've got something more than just good, better, you know, the monosyllabic responses of teenagers. And it helps their doctors calibrate their pharmaceuticals quick. So we can create a tool around that. And as we're creating a tool and getting them to do these like mini reflections during the day, it creates that metacognitive awareness, right? So that's big. That's hard for some students who have a difficult time task initiating anything. So depending on the student, do they need somebody else to help them with that? So that's an executive functioning tool for medication in particular. There's a tremendous amount of other executive functioning options for students in a school-related setting. That's mostly who we work with, whether it's middle school, high school, young adults. We do work with younger students as well, but most of those younger students that we work with, sort of upper elementary school, it's really working on some of those cognitive flexibility and frustration tolerance infrastructures at home to build that really important bedrock when they then get into the middle school years and the secondary school years where the workload really ramps up a lot. So for some of those home infrastructures, having a schedule, what does that look like? How many things should be on a schedule? Does color coding a schedule make a difference? How involved can a student be in owning that schedule so they don't feel like it's top down and they feel like they're getting some of the things that they need to do and want to do on that schedule? Who's going to be accountable for that schedule? How accountable are they going to be to that schedule? Does the student respond to natural consequences? Most do, some don't. And if they don't respond to natural consequences, what do we do in substitute for that? As they get into the middle and upper secondary school years and they are introduced to copious amounts of technology, there's a whole nother suite of executive functioning skills to make sure that, especially if attention-related concerns are a challenge, how do you stay on task? How do you organize? I mean, really right down to how do you organize your desktop, your email, your Google Calendar, your tab. I mean, there's just a suite of things that are available for students to use to help them cope, but understanding how to use them, which ones to use, which ones to pair with, which ones we absolutely should not use at all, because it's not a one size fit all. Sometimes with students who struggle with really significant attention-related concerns, we go back to what we used to call in the old day finder binders, where we take the technology away and we organize systems around making sure that the use of technology is strategic. But I mean, again, you see where the home pairing is important, because we can put those systems in place, but if that bedrock at home, which I mentioned before, Moon and her daughter had, are not aligned and there's not a coexisting sort of agreement on goals, then it's undone very quickly. When those things coexist together, it's really quite outstanding to see a young adult, a middle schooler who's been struggling to learn, feels like they're running backwards on a track while everyone's running forwards, they're frustrated, they've written off school, it's starting to affect them socially with friends, at home with relationships with families. It's really quite amazing to see them come into their own selves and find this potential that they started to convince themselves that they didn't have. So something we're always keeping note of when we do our work is motivation, self-esteem, self-efficacy. And that triangle of understanding and belief in oneself is really important. So how can I be motivated to get up and go to school? What systems do I need to be in place to do that? Because getting up in the dark and getting on a bus is not very inspirational, even for most adults, to go to work for 7 hours and then have a part 2 of your day to do homework. Self-esteem, how do I feel about myself? And if I feel terrible and I don't feel like I'm worth anyone's time or worth myself, then we've got to exist with a counselor. Self-efficacy is a real tricky one, and that's a real delicate one. That's the belief that I can be successful. And at the point in which that one starts to become precariously, it's in danger of becoming an issue for an individual, then we've got a problem. That's a sign for me that a student has really had quite a long trajectory or runway of unsuccessful learning experiences. And we need to tool up very quickly, but in small, significant ways, so there's some immediate gratification. And they can see how some systems in place, just some little tweaks to what they do every day, can help them feel like things aren't so hard. So that's a lot of what we do. It's very personalized. The med diary would be an example of how we help students who are introduced to pharmaceuticals understand what that's like. So it's not just taking something and then not really paying attention to how they're reacting to it. Digital executive functioning tools are really important, especially as students become more and more accustomed to online learning platforms, which became the norm for the global existence of the world in the last 2 years. How to take notes, how not to take notes, how to study for a test, what's the difference between active study skills and passive study skills, what do they look like? None of these things are difficult, and there's a lot of science behind this too. So, there's a lot of available things for parents to read about if they want to look into, okay, well, what does the cognitive science say about really strong metacognitive learning strategies? It's all out there. And then working with an executive functioning coach or even a teacher at school who can take that concept and convert it into a learning space that makes sense for the student is really important too. And then the effects are quite immediate. They can see the difference. That the effort that I was putting in for the test and the outcome are starting to become a little bit more correlated rather than cross-sectional.
Thank you so much. We will just answer some questions that we have on our Q&A. But Dr. Rogers, I just want to ask, how old can kids come to the program? And we also have a member from the audience, Lena, asking, is it a one-to-one or is it a group size program?
Yeah, we used to run seminars or workshops for middle schools. I mean, COVID has not allowed us to do that. Depending on the need, we run small group settings. So I don't do anything more than 15 because I tend to find that then, with executive functioning skills, especially because we've talked about this many times today, how personalized it is. It's not mass manufactured so that one size fits all. Although there are some tools that's systemic, like everybody should have a calendar. It's your number one study tool, right? So like, well, what does that look like for each student? Sometimes it's a digital calendar, sometimes it's paper calendar, sometimes it's a combination of both. So small group settings for students who are a little bit older, kind of upper middle school, early secondary school, assuming that they already have some systems in place at home and a routine and a schedule, and we're not trying to convince them that this is something that they need so we don't have opposition. That works. One-to-one is almost better for anything. I mean, if you're doing one-to-one learning in math versus one-to-one learning in a group setting, one-to-one learning about an essay structure, but that's not always viable from a time and feasibility perspective. So, again, it really does differ. We have not resumed small groups as of now because of COVID restrictions. But that doesn't mean that, people who are looking, parents who are looking today, who are listening to this, well, what do I do then? if you tap into your schools, and I mean, I think I alluded to this earlier, COVID really did bring to the surface the importance of executive functioning skills. It's always been important, but we just haven't really made it a primary conversation in the learning space until recently. Many schools are starting to do something with this in the capacity in which they can. And so tapping into your teachers and asking your teachers, if your child struggles with paying attention during the day, there are small but significant things that if they're working on a computer and that's not working for them, you can ask that teacher to print out a resource and to give the computer to, I mean, there are very simple things that can, highlighters, that's a big help depending on what their need is. So, you know, again, the group setting, the one-to-one setting, they both are helpful, I think, depending on the individual and their need. For some students, a one-to-one setting is really where they need to go to skill up quickly, and then they can integrate a little bit more into a bigger group setting.
Okay, fantastic. Now, I would like to ask another member from the audience, Ming Chiu. She asked, how does the school, teachers, parents, and herself help her child in school? Maybe Dr. McCauley can help us with this. How can we help our child in school?
Yeah, I mean, all schools are different. And I think from my experience of working with lots of different schools, some schools are so much more willing to support and put support in place and understand the child and their individual needs. And I think one of the key things is having a holistic approach. So if the parents have figured out that something's working really well at home, then sharing that information with the teacher, for example, and especially where you've got big groups of kids in a class, okay, what can we do to support our child to remain focused? The parents can sit down with the teacher, almost like a parent-teacher conference, and say things like, oh, well, we find that if he's able to stand up in between doing tasks or work at a standing desk, for example, his attention is so much better. Something like that can be implemented into a classroom. You know, so we're not expecting teachers to, it's not kind of reinventing the wheel for every child who has a diagnosis of ADHD, but thinking about things like how can we work together and work consistently together to support this child? Because also for, and I'm talking about younger children here, but also for children, when they see that parents and teachers are working together, that strategies are kind of cutting across different environments, what you tend to find is actually that things work quicker and work better, especially for kids who are impulsive. What do we do to support them to put their hand up when they want to ask a question? And we're repeating the same things in a home environment. So that's really, really vital. You know, and I know with big schools and big groups, often teachers kind of say, well, we don't have the resources to help your one child when we've got 30 plus other children. And I think that's probably one of the biggest challenges for a lot of parents, is they feel that they're kind of fighting this battle by themselves at home, and that teachers and schools are perhaps not willing to implement strategies and put things in place. And I was looking at the Q&As just now, and one of the parents said, well, you know, how do we get the teachers or the schools to listen to what we're saying? Because as professionals, we write long reports, 20 plus pages, lots and lots of recommendations, but it's about the willingness. You know, we can't force somebody to do something. It's the willingness of that teacher to pick up that report and to read it and to look at the strategies. It's the willingness of the learning support department to take that complex report and turn it maybe into one A4 PDF document that a teacher can quickly pick up and look at. These are the issues that we might be seeing in a classroom. What do we do about it? So I think, unfortunately, a lot of support in a school situation is based on willingness, and I'm sure you all know that can be a challenge. We don't have a magic wand.
Just one more bit on that. As a teacher who has worked in schools who didn't have all of the info, one of the things that you can do as parents is, if you go down the assessment route, share that with schools. Don't pare down the assessment. Don't chop it up into little bits. Schools are not going to broadcast student profiles out on the PA system with the morning announcements. They're very good at protecting a student's profile, but also they want to champion your kids and see them succeed. So if you have information in context that you have gleaned from visiting with professionals who have completed assessments, give that to the school. And then, you know, the other bit that Louise and I particularly work very closely on is, how do I help the parents understand what the next steps with the school are? what are some of the school learning language? If what are their pain points? What can you ask for that really is within their bandwidth of helping you? And what is outside that you really need to sort of search externally for additional support? Because, schools will always optimize and maximize what they can do for every child, but depending on the child, that may or may not be enough. So send the report in, have them ask them what next steps are for that particular. There's usually a little bit of a protocol that's similar, irrespective of the school, but keeping that report at home. And similarly, if you visit with Dr. Abraham or Dr. Quek and pharmaceuticals are something that you go down the road of and decide that that's what you're going to do with your child, make sure that they know that they're taking medication in the morning along with the Flintstone vitamin. The transparency and the communication and the collaboration between you and your child are very, very important. Louise does a really good job of making sure that students understand what some of their results are as well. So it doesn't just become this overwhelming, I sat for 4 hours and did this assessment, and to what end? So having them understand their learning language and their learning profile is really actually an important first step to getting them to understand, okay, well, that's the what. What's the so what? Well, the so what is we need to work on some executive functioning strategies. The so what is we need to put a routine in at home. The so what is, right? So please share information that you end up getting, and know that schools will keep that in a very safe space and use it to help support your kids.
I think that's wonderful information. I think it's also important to have a very good relationship, a good working relationship with the teacher, and always appreciate what the teacher is doing, because this is really additional work for a lot of teachers to do. Yeah, so long as we have open communication with the teachers, I think that could also be helpful. We have a lot of questions, but we can only take one last one. And we have a question from Tian Hong. And, this sounds great, but sometimes parents do face financial burden. What are some of the simple tips for parents or children that they can do at home with their kids? If in the event they are not financially able to see a professional for this. Maybe Dr. Quek can share some simple tips for parents if they are not financially able to visit the doctors and get professional help.
Okay, so just to address the financial part, if the family is Singaporean or PR, you can still go to the polyclinics and get referrals to for the preschoolers to either KK or NUH, the child development units there, right? And everything will be subsidized. It's still considered part of medical care, or a referral to IMH for school-age children, right? So for locals, there is no denial of medical service and access to either a pediatrician or a psychiatrist, right? It's just that, we all know that then, you don't get to choose your doctor, the waiting time may be a bit longer, but you get there, right? Once you have access into the medical services, that's when this doctors can also then get the child access to the psychologist. So all the testing that Dr. McCauley has been mentioning can be done from the government hospitals as well. We all have educational psychologists and clinical psychologists who do the behavioral work accessible to all our population, right? So the sphere that, we work in the private sector, we deal, at least 50-50 between completely private expat population and local population, right? But definitely local population, if you're really concerned and you want access to a doctor, go to the polyclinics and get a subsidy. Ongoing treatment is all subsidized. If there's still a lot of financial concerns, then get the referrals to the medical social worker, or hospitals have medical social workers. I've worked in government hospitals. We always tell the MSW for help. So there's no denial of medical care for any child, for either the physical or the mental health. Just get the social workers involved to, tap onto whichever funding government has to support the child, right? In terms of, tips to help the child, again, depending a lot on, nothing is one size fits all. A lot depends on the age of the child and the family dynamics, right? If both parents are working, child is in student care or childcare, right? Then there's a completely different set of possible behavior strategies. But essentially, what it does boil down to is this: very consistent boundaries, what is allowed, what is not allowed, even if, and I see some of the questions are asking, is it ADHD or is it just bad behavior, right? For some behaviors, it doesn't really matter. If you go around hitting another kid, at the end of the day, I can understand why you hit the other kid, because impulsive behavior, but the bottom line is you cannot hit another child, right? So the parenting boundaries, the behavior boundaries are very consistent. I tend to find sometimes that if the child is always in a school environment or in a student care environment, the boundaries are consistent because you run the student care like a school or childcare like a school. Boundaries are less consistent between school and home, right? And between parents and grandparents and helpers, right? So a lot of the challenge is making sure that the expectations, the behavior expectations are consistent throughout all the carers. Having a structure at home, a sort of timetable at home doesn't have to be as tight as school, but there's a general timetable for home activity is also very useful, because many of these kids do need to be forewarned that something is going to happen. That is, in 10 minutes, you're going to sit down and you're going to do your work, right? And after you finish your work, that is when you can have your screen time or go out and play. Many of the primary school kids will negotiate. Let me play with the computer first and then I'll do my work. Never works, ever. So do work first, then your reward is your screen time. But if you don't get the work done, there's no screen time, full stop, right? But that opens a whole different argument about screen time. Okay, so the older kids learn how to negotiate. We don't always have to bow to them, right? Parenting boundaries need to be very, very consistent. And for teenagers, it's harder just because they have more freedom to go about the day. Right, but the expectations are still very, very consistent. And in many cases, sometimes I ask the parents, even though you're parenting a teenager, you have to treat the teenager as if you're parenting a primary school child, because the teenager is not mature enough to make the kind of decisions, even though they think they are.
Thank you so much to our panelists for being here today, for volunteering your time. UA is forever grateful to you. Thank you so much. And the panelists may wish to leave because I understand they also have other commitments. Thank you so much. To our audience, please help us to fill in our feedback form, and please feel free, in the Q&A, please share with us what are the 1 or 2 takeaways that you have for this session. We would really, really love to hear from you. Please send us a feedback form, and please please also remember our upcoming webinar that we're going to have, that we're going to hear from our fathers with their ADHD children. Do we also have anything to say from Moon? Maybe we can hear from Moon to end this off. Thank you so much. Yes,
thank you again. Some of the panelists had to leave because they have appointments. Dr. Abraham, thank you as well. We really appreciate your presence here and for all the information. I'm hoping that we can do a part 2, because definitely, we have so many questions, and we don't have enough time, but please keep the conversations going. I think you've heard what the panelists were sharing earlier. It's important for parents to be involved in the care and the management of ADHD for the children. It is one of the things that we can't exactly outsource. I know as parents, and myself included, we're so used to sending kids to a tuition for whatever, and then someone else takes care of them. But in this particular situation, for the best outcome actually is to have that teamwork where the parent and child are part of a team, and also to have a team of professionals that you can work with. In my situation with my daughter, we had a very good team, of psychiatrists, psychologists, and all the others that really help us to understand what ADHD is about, and also how to manage things better. That doesn't mean that we don't have hiccups. We have tons of hiccups. I know we're still having hiccups, but the key thing is really to have that attitude of learning and just picking oneself up and then trying again. So to help all of you out there, we do have a support group on Facebook. right now, and we are looking at launching virtual support groups that are demographically segmented next month. So we will have support groups of parents of children under 12, parents of children, of teenagers, youth, adults, so on and so forth. So right now, go to our Facebook support group, go to our Facebook page and like it, because we do share articles that would be relevant and useful. This webinar is being recorded and we will be sharing the recording. We have prepared bonus slides for you with useful information about symptoms, diagnosis, and where to go and all that. So we will be sharing it as a photo album on the Unlocking ADHD Facebook, and we will also be sending a link in the email to you.